Pathology of AGN, acute glomerulonephritis. On a light microscopy, the glomeruli are enlarged and ischemic, and the capillary loops are narrowed, making the glomeruli appear bloodless. So basically, it looks like ghost. Bloodless capillaries will be there, which is nothing but the glomeruli. There is mesangial proliferation and neutrophil infiltration. Okay, and then immunofluorescence will show IgG granular deposits and C3 along the capillary walls. Electron microscopy will show humps on the subepithelial side of the GBM, glomerular basement membrane. It's in the SEP, the subepithelial. Okay, subepithelial side of the glomerular basement membrane. So that's the pathology. And then clinical features, post-streptococcal glomerulonephritis. It affects school-age children, more commonly boys, and is uncommon below 3 years. Subclinical episodes are more common than overt disease, especially during epidemics. The onset is rapid with puffiness around the eyes and pedal edema. Urine is cola colored, hematuria is brief, often lasting only a few hours and does not persist beyond 1 to 2 weeks. So, yeah, okay. PSGN, the typical age group which is going to be affected is school aged, but and which sex is going to be boys. But then under 3 years of age, the children do not go to school, right? So under 3 years is pretty rare. And then subclinical episodes are more common than clinical episodes. And then epidemics can also happen. And then type of episode is subclinical. Okay, and then the onset is rapid. And then what is the clinical feature? There is puffiness around the eyes and pedal edema. And then the color of the urine is cola colored urine. Hematuria is brief and it lasts only for a few hours. Maximum is going to be 1 to 2 weeks. Okay, beyond that the hematuria does not happen. While the degree of oliguria correlates with the severity of disease, anuria is common. So like the quantity of the urine, quality and quantity. Quality, it's blood in the pee. Quantity, there is oliguria. Oliguria correlates with the severity, but anuria is uncommon. Okay, hypertension is present in half of the patients. It resolves with loss of edema. So as edema goes, hypertension also goes. Atypical presentations include because of complications like heart and brain and like the kidney. Okay, so with the kidney itself, we have two things: nephrotic syndrome and AKI. AKI is acute kidney injury. Okay, and with the brain, there could be convulsions because of hypertensive encephalopathy, and because there is heart failure, left ventricular failure and pulmonary edema can also happen due to malignant hypertension and hypervolemia because oliguria. So urine is not produced avalava. So all the blood which is accumulating in the body is going to cause hypervolemia, right? So a lot of volume is going to cause hypertension. The hypertension causes encephalopathy. Encephalopathy causes convulsions. So like the child just throws seizures. Hmm. So that's about the clinical feature, the age of onset, the sex, the type of presentation is subclinical, onset is rapid. We know the clinical features ho-ho along with the puffiness of the around the eyes and pedal edema, urine quantity, quality, and then atypical presentations. Okay, moving on to the laboratory findings. Urine shows 1 plus or 2 plus proteins. Protein will be there with RBCs. RBC will be there and red cell and granular cast. What kind of cast? RBC cast and granular cast will be there. Okay. WBCs may be present. If it is present, it indicates glomerular inflammation. It should not be regarded as evidence of UTI. Hemodilution may result in normocytic anemia. Okay, it's because of hemodilution. Why is the hemodilution? Because the child does not pee that much. So oliguria இருக்கு அதனால அப்படியே bloodல வந்து water is going to accumulate. So anemia வந்து it's because of dilution. So it's normocytic normochromic anemia. ESR is elevated. BUN-C is elevated. Blood urea nitrogen creatinine elevated. What does it indicate? It indicates renal impairment. Hyponatremia, hyperkalemia occurs because of oliguria. Chest X-ray may show prominent vascular markings suggesting hypervolemia. So, okay, so like a kidney problem ko எதுக்கு chest X-ray எடுக்கணும்னு பார்த்தாக்கா it's for this hyper markings. Okay, increased markings in the okay, prominent vascular markings in the chest X-ray suggesting hypervolemia.